Okay, so children with ADHD and symptoms of anxiety and depression often need accommodations and supports at school. You can ask for a 504 plan or an IEP. So we're going to talk about what are they and what's the difference. Both can offer formal help. Depending on what state you're in, it can be K through 12, or some IEPs in some states start at age 3 in preschool. It can help with learning and attention issues. Both are provided at no cost to families. A caregiver's written consent is required for the school district to evaluate the child. This is often a barrier. It's a very long packet. A lot of information has to be turned in, and sometimes families need help completing this packet and turning it in and actually requesting and providing consent and all the information to obtain the evaluation. So a 504 plan and IEPs are very similar in some ways, very different in others, so we're going to talk about that in a little bit of detail. Here's a chart which compares them side by side to help you understand the differences. So an IEP is really focused on the special education experience, whereas a 504 plan talks about how a child will have access to learning. An IEP talks about related services to meet the unique needs of the child. The 504 plan may also provide services. It's really focusing on having the child learn and as adequately as other students. There are different laws that guide each, IDEA versus the Section 504 of the Rehabilitation Act. Who is eligible? And eligibility for an IEP is more strict. A child has to have one or more of 13 specific disabilities listed. Learning and attention issues may qualify. A child with ADHD may qualify as a child with other health impairment. A child with a learning disorder may qualify as a child with a specific learning disability. But the disability must affect the child's educational performance. Some children that have a medical diagnosis of autism spectrum disorder, if they're very high functioning, they may not meet school eligibility criteria. And it's confusing for families. 504 plan is more lenient. A child has to have any disability, which may include many learning or attention issues that interferes with the child's ability to learn in a general education classroom. It has a broader definition of disability than IDEA, which guides an IEP. Who creates the program and plan? The IEP has very strict legal requirements about who participates. The team must include a caregiver, a general education teacher, special education teacher, school psychologist, or other specialist who can interpret evaluation results, and a district representative. The rules are less specific for a 504 plan. It's just a team of people who are familiar with the child. It often includes a caregiver, a teacher, a parent, a principal. An IEP is a legal written standard document. A 504, it should be written. There's no standard. What's in the program? An IEP is very specific. It has specific learning goals. It has to present levels of educational and functional performance, what services will be provided, the timing of those services, accommodations and modifications. What's the difference? Accommodations are changes to the child's learning environment, whereas modifications are changes to what the child is expected to learn or know. A 504 plan gives specific accommodations and supports and services, the names of who will provide each, and who's responsible for implementing them, but it's not as specific. And an IEP must be reviewed at least once a year. You have your annual IEP meeting. A child is reevaluated, receives a full psychoeducational evaluation every 3 years or triennial, or sooner by request. So a lot of families need to be told that they can request a reevaluation sooner or have an IEP meeting at any time by request. They don't have to wait that full year or 3 years. 504 plans, the rules vary by state. They're generally reviewed each year. Sometimes they forget to do that part and just reevaluate when needed. So oftentimes a child with straight garden variety ADHD, a 504 plan may be sufficient. They may be evaluated to determine eligibility for special education services, and they may not qualify, but a 504 plan may work. The challenge is that it's not as specific, and communication between parents and teachers is key to make sure that the accommodations are being carried out and to reevaluate to see if it's working or needs to be changed over time. So let's get back to Luke. He is now in our DBP clinic. We're getting our comprehensive history. Luke was 8 years old when he was originally diagnosed with ADHD. At that time, he was having trouble paying attention. He was handing in assignments late. He was having difficulty organizing tasks and was always in others' personal space. Here are his previous accommodations. He had preferred seating, he had planned breaks, small group activities. A daily report card is very, very common. They're commonly used for children in elementary school age. So a child gets a positive reward for how they're doing, and you can track how they're doing visually. So what type of educational support plan was Luke likely getting? A FAPE. B, 504 service plan, C, IDEA, D, IEP, so use your clickers. Yes, he was likely getting a 504 plan, exactly. FAPE is not a plan, that's the Free Access to Public Education. IDEA is the law, the Individual for Disabilities Education Act. And probably these were accommodations that were in a 504 plan. So when Luke came to DBP Clinic, they brought the psychoeducational testing that was done at the school district 1 month ago. So we had that to review. We're going to talk about how to interpret these test scores, what domains may be assessed. It's variable. Ideally, these are all the different areas you might consider. We're going to just give definitions of them. Intellectual functioning is a global measure of ability. Academic achievement, your specific academic abilities in reading, writing, math. Language, it looks at both reception and expression. May also look at speech and articulation. Memory, short and long term, visual and verbal memory. Visual spatial skills, how you can manipulate and recognize visual information. Attention, concentration. Executive function, we're going to talk about that in more detail in a little bit. Fine motor control, how you use your hands and small muscles for writing and buttoning, behavioral and emotional functioning, social skills, and of course adaptive functioning, your ability to complete activities of daily life. The school gave all of these tests and they provided all of these standard scores. What is a standard score? It compares a child's abilities to what would be expected for someone of the same age. They may be reported as a standard score, which depending on what scale you're using, they have different means and standard deviations. There are percentile ranks. They may be given age equivalents or grade equivalents. So we talked to the family, and the family hands the report over, and we realized that they don't understand what the scores mean. That happens a lot. And so understanding the psychoeducational testing results is important for parents because A, it places blame on the school for the child's difficulties. B, you have objective data that provides information about a child's strengths and difficulties and how the child experiences life. C, it guides the treatment plan, educational parenting strategies. D, B, and C. Use your clickers. Yes, B and C, that is correct. So it's nice to be able to help the family understand the scores and what they mean. It's often helpful to show a graph, the standard bell curve or the normal curve. A visual often helps. So you can show the family the range, scores in the middle of the graph are considered average or within normal limits. Scores on the left-hand side are below the expected range. Scores on the right-hand side are above the expected range. You can see the majority of children score within the average range with less and less people scoring as you go farther and farther out. It's often helpful to talk to parents in terms of percentiles or age or grade equivalents rather than standard scores. So if a child receives an IQ score at the 75th percentile, we know that a child performed better than 75% of children of the same age who took that test. I often use height to explain it to parents. So if 100 children were in a line and a child performed at the 99th percentile, they would be 99th in line, taller than all the other kids. So it's helpful to have that visual. Standard score interpretation, I include these charts in all of our reports. I think it's helpful for parents to facilitate understanding. It's confusing for caregivers, it's confusing for us because publishers vary slightly on their classification descriptors. So for example, the Wechsler tests consider a standard score of 110 or a scaled score of 12 to be high average, but many other tests consider that to be average. So we recommend choose what works for you and be consistent. It's confusing for families if they see different terms described in different ways. They think you made a mistake. And then you hear about it. So this is what we commonly use, but use whatever works for you. So now that we understand standard scores, we can look at Luke's WISC-5 scores. He was administered the WISC-5, which is an intelligence test for children. And here are his scores. So you can see that his verbal comprehension reasoning abilities were solidly within the average range. He showed a strength in visual spatial reasoning abilities, which were high average, as well as fluid reasoning abilities, his ability to figure out and apply and solve a problem. Working memory and processing speed were relative weaknesses. They were both in the low average range. That's very commonly seen in children with ADHD. And his full-scale IQ score was in the average range, but that score is not valid due to the significant scatter among indices that are combined to generate this score. And then you can look at the subtests in a little bit more detail to see if there are any discrepancies. He kept it easy for us and was very consistent. Thanks, Luke. Fictional Luke. So you can see again that block design and visual puzzles and the visual spatial index, as well as the measures of fluid reasoning were above average in relative strengths. And then working memory, look at that digit span. That was very, very difficult for him, his ability to recall digits forwards, backwards, and then sequenced. It was hard for him to hold and manipulate information in his mind. And processing speed was lower as well. It might have been harder for him to sustain his attention to those tasks for the full 2 minutes. The school also gave academic testing. They gave him the Woodcock-Johnson 4th edition, which is a measure of basic academic concepts. Luke is currently in the 6th grade, and so we'll look at his age equivalent scores. Here are his reading scores. He had a lot of difficulty with reading words, word identification, understanding what was read to him, as well as fluency. And his overall reading score was in the borderline range. If you look at his grade equivalents, we know he's in the 6th grade, and he's pretty consistently performing at the 4th grade equivalent, so significantly below other children his grade. Math was all solidly in the average range, and writing was also within the average range. So here's a quiz. Luke's scores suggest A, no diagnosis, B, a learning disability in the area of writing, C, a learning disability in the area of reading, D, ADHD. Click. Yes, these scores definitely do suggest a learning disability in the area of reading. These tests were not used to evaluate symptoms of ADHD. I mean, on the IQ testing, his profile was consistent with someone with ADHD, but it's not diagnostic in itself. But the scores are diagnostic of a learning disability in the area of reading. Luke had difficulty with all areas of reading, with word reading accuracy, how he could pronounce the words, his reading rate, how quickly he read, as well as reading comprehension. So after this updated testing, he was found to be eligible for special education services as a child with a specific learning disability, and his IEP was formulated accordingly. People often ask, well, how much of this is related to inattention? You know, we know he has ADHD. Is that the primary cause of his learning difficulties? You know, based on his scores, I would say no. His functional performance is significantly below where it should be, and he's having trouble with just reading the words and understanding what he's reading and reading quickly. So it's possible that inattention and organizational difficulties are exacerbating his reading problems. He might have trouble attending to the salient information and encoding that information and recalling it in an organized fashion. But his scores are significantly below where they should be. It's causing functional impairment, and he should receive treatments and accommodations to help with reading. So he does meet criteria as a child with a comorbid learning disability, and he needs services accordingly. And it's very, very common for children with ADHD to have a comorbid learning disability. So in clinic, we review his IEP goals. Now he has pull-out specialized academic instruction 2 times per week for 40 minutes. He also has some push-in supports to help him with accommodations within the classroom. And we always recommend individual tutoring utilizing a multisensory approach. There are different evidence-based approaches that you've probably heard of, the Lindemood-Bell, Slingerland, the Orton-Gillingham approach. So we just recommend using any evidence-based multisensory approach. Okay.
So now we're going to talk about some of the physical conditions that may mimic ADHD or in some cases coexist with ADHD. So it's really important to take a good sleep history because we know when people are low on sleep, they absolutely have problems with attention, with organization, with their executive functioning. So we want to ask questions like, do they have symptoms of restless leg syndrome? So do the kids feel like they always have to be moving their legs? And in fact, this may cause them to have difficulty falling asleep because they're having this issue when they're lying in bed trying to fall asleep. Do they have snoring? Or do their parents hear pauses in their breathing, indicating that they might have sleep apnea, which can lead to disrupted sleep? Do they have symptoms of heat intolerance, which could make you think that perhaps hyperthyroidism is going on, or cold intolerance, which would make you concerned about hypothyroidism? Do they have staring spells? And we know that kids who have inattention are often staring off, daydreaming. So we're going to talk shortly, next slide, about some factors that might help you differentiate when you should be concerned about seizures and when you should get that EEG. You also need to take a really good history about what medications they're on, about whether they might be using illicit substances that could also potentially produce an ADHD-like picture. So there was a really good article published 20 years ago now in the Journal of Pediatrics that helped isolate some features that would make you think, yes, the kid is staring, but this is probably not a seizure. You don't have to get that EEG. And those factors that they found included if the staring spells ever interrupted playing or some other activity. So if they never interrupt an activity, like you don't get a history that they're in the middle of eating and then they just stop and stare, or in the middle of a sentence just stop and stare, then that kind of no interruption is going to make you think it's more just inattention staring, not epilepsy staring. Also, if you say their name and they come back out of that staring spell right away, but you often will not see that with an ADHD, they kind of ignore you. But if you go up to them and physically touch them and they right away respond, then that would not be so concerning for a seizure. As far as factors that would make you concerned about a seizure and would push you to think more about ordering that EEG, of course, if there's not preserved responsiveness to touch, of course, if there's interrupting activities, but also if there are limb twitches, upward eye movements accompanying the staring spell, urinary incontinence, or amnesia for the period during which they were doing the staring. So it's also important to think about whether or not there are jerky movements or vocalizations. Now we know that among children with ADHD, the prevalence rate of chronic tic disorders is around 20%, although this is not always full-blown Tourette's. People often wonder, okay, how do you define Tourette syndrome? Important to think about because 60% of kids with Tourette syndrome have ADHD. Tourette syndrome, the criteria include having 2 or more motor tics and at least 1 vocal tic. So both the motor and the vocal, they have to have had tics for at least a year, but the tics don't need to be daily. For that year, they could be intermittent. And the tics have to begin before 18 years of age, and they have to have these tics that are not due to taking a medication or to another medical condition. So it's really important. Sometimes it's kind of like, okay, we're in a really kind of limited time here, so we're just talking about ADHD, so we don't need to do the physical exam. But we might think that, but it's just really important for the physical exam to rule out mimicking comorbid or predisposing conditions. So American Academy of Pediatrics wants to remind you to conduct a hearing and vision screen because hearing or visual impairment may produce an ADHD-like picture. We also really want to look at the height and the weight, the growth curves. If those are off, that might make you think that perhaps a hypo or hyperthyroidism is going on. In addition, kind of the being a short stature or having head circumference abnormalities, either micro or macrocephaly, having dysmorphic features or skin stigmata could tip you off that a neurodevelopmental or genetic syndrome is going on. And next slide, we'll review some of the syndromes to think about where there are increased rates of ADHD. But since so many physical conditions can mimic ADHD, almost all elements of the physical exam are important. Even vital signs. Bradycardia is going to make you think, okay, is hypothyroidism going on? Tachycardia, you're thinking about maybe it's hyperthyroidism, or maybe there's some medications or illicit substances that are producing an ADHD-like picture. Your neck exam may tip you off to thyroid problems too. So let's think about some genetic conditions that have higher rates of ADHD than the typical population. So I have kind of two bins here for you. One are genetic conditions where there's, usually you don't see intellectual disability, although you can frequently see a comorbid LD. So Turner syndrome is one of those, and so say this child has a nonverbal learning disability where their visual spatial skills classically are going to be below their verbal skills. They have short stature. It's a girl with short stature sometimes, but sometimes not. You might see a webbed neck or widely spaced nipples. Neurofibromatosis, you're looking for those cafe au lait spots, those neurofibromas. They have macrocephaly. What about Marfan syndrome? Also, you can see higher rates of ADHD, so those, kind of long, arms and legs, those tapering fingers, and also frequently a comorbid LD with your ADHD. How about the picture of the kiddo on the lower left-hand corner? So this kid has smaller nasal ali, and effectively, so you look in their throat, and they had a bifid uvula, which is tipping you off that they might have a submucoid cleft palate. So what condition that has higher rates of ADHD than general population might you guys be worried about for that kid? Absolutely. So you guys, I have to say, how you're doing on the clicker, you guys are total stars. So velo-cardiofacial syndrome, absolutely, and they may have some congenital heart defect as well. So some conditions with intellectual disability that have higher rates of ADHD than the general population. So Down syndrome, I think everyone's pretty well familiar with Down syndrome, as well as tuberous sclerosis, with the ash leaf spots, and also you can see tubers. How about this kiddo in the middle here, who has macrocephaly and also kind of prominent ears? Absolutely. Okay, and then how about the kid on the lower right? So this kid has short stature, microcephaly, and then the elfin facies and stellate pattern to the irises. Yep, absolutely. So if you are worried about that there's some kind of elements of the physical exam, that the history that might make you suspicious of a genetic syndrome, then you are going to order testing. And certainly any kid who has an intellectual disability, the gold standard recommendations are to get chromosomal testing, preferably microarray, as well as Fragile X testing. So what about ADHD? So say you don't have any, you don't have those particular concerns. Should you get lab tests for every single patient? So there are no lab tests that are diagnostic for ADHD, so they're not routinely recommended, but tests may be ordered as indicated based upon the history and the physical exam. So for instance, if there's a history that they live in, old housing and they have all these, they're always putting things in their mouths, then you probably want to get a lead level to make sure that there's an ongoing lead exposure, which can put you at increased risk for ADHD and ADHD symptoms. We talked about different things that might tip you off, the need to check thyroid function tests. If they have these restless leg symptoms, then you would want to get iron and ferritin levels, since low iron stores can predispose you to restless leg syndrome, as well as periodic limb movement disorder. So these extra movements during sleep that can lead to micro-arousals and poor sleep. And then, of course, the genetic testing that we discussed. So what about ordering neuroimaging studies, or EEG? So although group means for those with ADHD versus controls do differ significantly in many imaging and EEG studies, there is so much overlap between kids with ADHD and kids without. These are not routinely recommended for diagnostic evaluation, even though there was kind of an EEG test that did get some FDA approval for being kind of an adjunct to ADHD diagnosis. Since it's only an adjunct and doesn't make or break your diagnosis, that's still based upon the clinical characteristics. It's actually not, recommended on a routine basis to get that. There's these books out there, I think it's by Dr. Amen, about how, you can do a neuroimaging study and identify these different neuroimaging patterns that would, lead you to kind of have these different varieties of ADHD. There's really no good evidence. There's no research underlying that book. So kind of quiet down the families that they don't need to travel to Texas and get his fancy, expensive neuroimaging. As far as, of course, there could be some situations, as we discussed, with the staring spells or other features suggesting seizures, in which you would get the EEG or a focal neurologic exam, in which, you would get an MRI. So there are, for additional information about some physical conditions that can mimic, predispose, or comorbid medical conditions, I did work on an article on this for expert reviews in neurotherapeutics, and there's also Up to Date is an excellent online resource. So as far as our differential diagnosis for Luke here, we have ADHD, we have anxiety and depression, oppositional defiant disorder, learning disability. Actually, it's not just kind of on the table. We've already, with our test scores, ruled that in. And then we're also thinking about sleep disorder, and, hypothyroidism was, something that a person could think about in terms of the fatigue that he has. So it wouldn't be wrong if, based upon that, you wanted to get the thyroid studies.
Okay, so we need to collect more information about Luke's behavioral functioning to figure out what to keep on our diagnostic differential and what does not apply. So we're getting more history. We know that Luke has continued to take Concerta, 36 milligrams every morning. We got updated Vanderbilt rating forms, and we compare them with the pre-treatment scores obtained in primary care. And we see that Luke continues to display significant behavioral symptoms of ADHD that do impact his function. Here are his current Vanderbilt scores. We had separate ratings from father, mother, and teacher. All are consistently reporting symptoms of inattention. Mom is reporting symptoms of hyperactivity, impulsivity, but teacher and father are not reporting clinically significant difficulties. Mom and teacher did report clinically significant difficulties with inattention. If you remember, the original form said 9 out of 9, so it's gone down a little bit, but it's still 7 out of 9. Father's form is just sub-threshold, but he's still reporting significant difficulties in that area. Mom is also reporting clinically significant difficulties with oppositional defiant symptoms. The teacher is noticing these difficulties at school. Teacher and mother are noticing symptoms of anxiety and depression. Everyone is noticing difficulties with school and functional impact on behavior. So based on these scores and the history, you conclude A, no diagnosis, B, undertreated ADHD, predominantly inattentive presentation. C, undertreated ADHD, predominantly hyperactive impulsive presentation. And D, ADHD combined presentation. Get ready, click. Okay, the majority said undertreated ADHD, predominantly inattentive presentation. We would agree based on the current Vanderbilts. He does have a diagnosis of ADHD, he's on medication, but he's still displaying significant symptoms of inattention that are impacting his functioning. So we will still want to collect more information given the family's concerns about anxiety and depression. We get a BASC 3. We talked about the BASC this morning. So here are Luke's scores. We got ratings from his mother and from the teacher. You can see that his mother is worried in almost every area. She is tired. She is stressed out. He has a lot going on. She's with Luke a lot. The teacher doesn't notice difficulties as much, but the teacher is noticing difficulties with attention and learning problems and school problems, as well as some withdrawal. And here are the adaptive scales. There are difficulties noted in all areas, so it is impacting his daily functioning. And then on the older version of the BASC 3, it has these content probability scales. You can see difficulties in the ADHD area, as well as some other elevations. So parents are reporting more concerns with anxiety and depression than teacher, but both have similar concerns regarding attention, learning problems at school, and withdrawal. There are clinically significant or at-risk concerns in all adaptive skills. So we still need more information. What do we do with this? Here are a bunch of different assessment tools that you can use to get more information. So these are just here for your reference. These are specifically to evaluate symptoms of ADHD. We already know that. We're going to look at his mood. We know he's showing some symptoms of anxiety. Does he have social anxiety? Does he have generalized anxiety? Does he have clinically significant symptoms of depression? You already did your physical exam. It was unremarkable. No lab, EEG, or imaging studies were indicated. So we decide to give additional measures to further assess anxiety, depression, and executive function, given his difficulties at school and given his decreased scores in working memory and processing speed. So we give the SCARED. It's valid for children ages 8 to 18. There's a child form, there's a parent form. It's fast, it takes 10 minutes to complete. It's researched, it's found to be effective for use in primary care. Here's the website where it's available for free in the public domain. This is what it looks like. Here are a few of the questions, and here are the ratings. You can say 0 not true, 1 somewhat true, 2 very true, and then this is how you score it. You get a total score, and it separates it into different domains, looking at panic disorder, generalized anxiety disorder, separation anxiety, social anxiety, and school avoidance. So here are Luke's scores. His total score is 486. That's very high. A total score equal to or above 25 is indicative of a likely anxiety disorder. And you can see that he's showing difficulties with anxiety in a lot of different areas. Some symptoms of panic disorder, generalized anxiety, school anxiety, and school avoidance. So we also gave him a CDI to look at symptoms of depression. This is a self-report for ages 7 to 17. Here's how you interpret the scores. They're T-scores. And here are his scores. He got a T-score of 62, which places him in the high average range. High average is somewhat more concerns than typically reported. So you can see it's not, severely elevated or elevated, but it is a little bit above the expected range. So we gave this questionnaire looking at symptoms of depression. What else would you assess for related to this? A, risk for suicide. B, anxiety. C, bipolar disorder. D, screen time. Click. Yes, anytime you are worried about depression, we said this earlier, but we're going to reiterate, you always have to assess risk for suicide. You have to get comfortable asking, do you have thoughts of hurting yourself? Do you have thoughts of killing yourself? Assess for a plan, a means, an intent. So here's another tool that you could use, the PHQ-9. The benefit of this one is that it is free in the public domain. So we gave that one to him too, just for the purposes of showing. His score was 6, indicative of mild depression. So scores on the CDI and PHQ were comparable. And Luke does not currently have any suicidal ideation. We're also worried about his executive function. On the IEP testing results, we notice that he continues to have difficulties with working memory and processing speed. We're wondering if difficulties with executive function are impacting his performance. Children with ADHD usually do have difficulties with executive function. So what is executive function? You hear about it all the time. People describe it as a conductor of an orchestra. I say that it's your ability to plan and organize to achieve a goal. It's an umbrella term. It refers to multiple interrelated cognitive skills. There have been a lot of research studies looking at the brain basis of executive function. It's often attributed to the frontal lobes, and specifically the prefrontal cortex. We do know that other studies implicate, look at Posner studies of whole networks and other brain regions, and so it is believed to be impacted by regions and networks all throughout the brain. So here's a graph from a meta-analysis showing the development of executive function skills over time. So you can see that there's rapid development from early childhood, starting at 5, goes up. You'll notice this nice plateau in the teenage years, which is so telling. Yes, you'll hear parents say, "Why are you so stupid?" And they're not stupid, they just don't have fully developed executive function skills. They're not
stagnating at the moment.
They are plateauing. They're definitely plateauing. Your executive function skills continue to develop up until your 20s. Luckily, we're in pediatrics, so I'm not showing the other end of this graph, but what goes up does come down. If you look at it, there's an inverted U, so we might have all peaked by now. But we're in pediatrics, so. Okay, so executive function is often operationalized as having 3 main skills. People will debate about this. There's a lot of debate, so we're just going to simplify it and talk about it this way. Working memory is one skill that you look at. It's your ability to hold and manipulate information in your mind. A good example is remembering a phone number. That's why phone numbers were 7 digits, because typically the magic number was 7 plus or minus 2. But now we have to remember area codes too, so that is harder. If somebody says their whole phone number, you're trying to recite it to yourself and remember it to type it back in. Inhibition, your ability to stop an automatic or reflexive behavior. So blurting out an answer, you see a child who blurts out in class and they're supposed to raise their hand, and then they start raising their hand, but they're still blurting it out. So I talk to parents who have a child diagnosed with ADHD, and you talk about ready, aim, fire. They often go ready, fire, oops. So you have to teach them to slow down and to remember to aim. And cognitive flexibility is another component of executive function, your ability to switch or shift between tasks or rules. There are other higher level cognitive skills that are considered to be a part of executive function: planning and organizing, planning ahead, initiating an activity, just getting a child to sit down and to start their homework. It can be torturous. Selection of efficient problem-solving strategies, and monitoring. Is this working? Is my strategy working? Do I need to shift and do a different strategy, as well as monitoring your emotional regulation? Attention and processing speed are also components related to executive function. Attention is a multifaceted construct. And it's a core ability needed to acquire new skills and knowledge. If you can't attend, then you can't pay attention to learn the other information. There are different types of attention, which include selective attention, your ability to focus on relevant stimuli despite distractors. So we're really good at tuning out information that we don't need. Right now, you're all doing a really good job of ignoring the way your chair feels on you and the cold air blowing, so you can focus on what we're saying and what we're showing. Sustained attention, you're doing an excellent job of maintaining an alert state for an extended period, as well as divided attention. Too often, we're dividing our attention. We're on our phones and multitasking and doing a lot of different things at once. And then processing speed, how quickly you can discriminate and process usually visual information. That's oftentimes how we measure it. So You can measure executive function in different ways. There are measures that you can give, there are rating forms. You can also ask about it. So here are some questions that you can use to ask to understand if a child is having difficulties with executive function. Does your child have trouble remembering things? Does your child have trouble putting on the brakes? What's your morning routine like? Is it hard to get out of the door? Do they forget multi-step directions? Do they have trouble turning in assignments? So you can just ask these questions to get a better understanding of how their executive function is impacting them in the real world. So quiz, how is executive functioning assessed? A, parent-teacher report of EF skills on standardized rating scales. B, an MRI of the brain. C, direct assessment of EF can be performed through psychological, educational, or neuropsych testing. D, A and C. Ready, click. Yes, the answer is A and C. You can measure it using direct psychological testing or rating forms, not with an MRI of the brain. So there are some general behavior rating forms that give you information about executive function constructs, as well as there are specific executive function rating scales, such as the brief. There's the brief pre for preschool age and the brief 2 for older children. So we give Luke's parent a brief 2 to complete, and here are his scores. So you can see these again are T-scores, a mean of 50, a standard deviation of 10. Anything above 65 or greater is considered potentially clinically significant. So there are stars by the areas that are clinically significant. So Luke is having difficulties with executive function in the real world. You can do direct assessment of executive function. It's not necessary to diagnose something like attention deficit hyperactivity disorder. It can be helpful at times. It's definitely not something that you have to do. It's often difficult to access it. Here are some tests that are specifically designed to look at executive function, like the NEPC, the DCAFs, the MEFs. IQ tests include subtests that focus on components of EF, like working memory and processing speed. The CPT-3, we just wanted to mention it. There are some other, these computerized assessments of attention-related problems. The TOVA is another one. They're commonly used to evaluate attention. They're long, boring tasks. On the CPT, you have to just look and press the spacebar every time you see a letter, unless it's an X, and then you don't press. Sometimes they come really fast, and you're pressing. It's harder when they come really slowly. So you're staring at a blank screen, and you're staring and staring. So it can give you helpful information, but it should not be used to diagnose ADHD. That was not the purpose. Here's an example of a complex response inhibition task, the Stroop task. We're going to give it to you just so you can see what it feels like to do this. So we want you to name the color of the print to yourself. Okay, color of the print. Color of the print. Color of the print. Okay, now we want you to read the word. Read the word, read the word, read the word. Okay, which was easier? Yes, exactly. In the first one, we had to inhibit the overlearned response of reading to actually look at the print of the word. So it's harder. You can feel your brain actually working to do that. So this is just a table showing different ways to evaluate executive skills in children, and you're looking at different skills. So for example, if you're looking at response inhibition, you can just do this with your behavioral observations with the child. How does a child do beginning a task? Do they interrupt? Do they start a task before you've given all the instructions? Do they give up quickly? You can do formal testing. You can look at inhibition or statue or trails to look at response inhibition. You can use rating forms to evaluate it, and then you can also ask about behavioral manifestations of response inhibition at school, talking without raising your hand. So there are a lot of different ways that you can try to understand and look at difficulties with executive function. Okay, so now we've collected all of this information, so how is it going to inform our diagnostic conclusions? What are our diagnostic impressions for Luke? A, ADHD of the inattentive type. B, a learning disability in the area of reading. C, generalized anxiety, panic, social anxiety. D, all of the above. Click. Yes, all of the above. Based on all of the information that we've obtained, he's showing symptoms consistent with all of these things. He has anxiety that's clinically significant, that's interfering with his functioning, as well as ADHD and a learning disability. So, keep going?
Yeah, because this is the CBT part. Yeah.
Okay.
And then we'll take a break before timing. Go ahead.
Okay.
Yeah, no, we can, well, whatever.
Okay, well, there are a few slides we can do to take a break, or we can, okay, raise your hand if you want to break now. Okay, raise your hand if you want to keep going, because you're doing an amazing job with your sustained attention. Okay, so we are going to talk about DBP treatment approaches. Parent training to teach behavioral management strategies is an excellent evidence-based approach to treat symptoms of ADHD. ADHD affects the entire family. It can be exhausting, so behavioral therapy should involve all members of the household. So caregivers really need to understand ADHD as a neurophysiologic deficiency. It's not just that the child is lazy or is not motivated or is not trying. It's actually harder for the child to organize and to inhibit impulses and complete tasks of daily living. There are some evidence-based programs which are listed here. The New Forest Therapy, Triple P, Incredible Years, PCIT. So it's definitely good to be aware of these evidence-based parent management training programs. Sometimes you can find a provider who can teach you these strategies. Some of these have a lot of information online, but they are short-term and evidence-based and very effective and helpful. We also recommend CBT therapy. Cognitive behavioral therapy is the first-line treatment for anxiety in children. It has not been shown in large-scale research studies to be effective for treating ADHD. So what is CBT? It uses an individual's thinking skills to control their behavioral response. It acknowledges that behaviors and emotions that cannot be controlled through rational thought because they're triggered responses by external or internal stimuli based on prior learning. It's problem-focused, it's action-oriented. It uses specific strategies like modeling, rehearsal, role-playing. We saw earlier that the girl with anxiety and depression was catastrophizing. So one thing led to another, led to another, led to another. It's the most effective form of treatment for anxiety, and it can also be helpful to regulate mood, control impulses, modify other behaviors. But again, there's less evidence for all of that. So the premise are that thoughts and behavior affect your feelings, or these automatic or habitual thoughts. So you have to have self-awareness about what these are. There's always going to be stress in life, things that you can't change, and then there are things that you can change, such as your reaction to it. You have to practice these skills. So here is an example of negative thoughts and behavior, the mood spiraling down, which we saw one of these earlier. The friend didn't say hi. You have decreased eye contact, you avoid other people, you generalize, I have no friends, you catastrophize, I'm worthless, I'm feeling helpless. So CBT also involves relaxation, teaching relaxation techniques through deep breathing or visualization. You can combine these techniques. You can do progressive muscle relaxation. That's a great one to teach kids of all ages. It's something they can do anywhere, anytime, in bed, before they go to sleep, before they take a test. Yoga can teach mindfulness. General exercise is helpful. And this is one thing that we often recommend because it's an evidence-based program that uses cognitive behavioral therapeutic approaches to address anxiety. It was designed for school-age children, ages 7 to 13. It's time-limited, so over 12 to 16 weeks. It has manuals that you can literally buy online on Amazon. They're about $20 each. There's a child manual, a caregiver manual, so they can learn the strategies and follow along, as well as a therapist manual. I would never encourage families to just buy the manuals and do them on their own because it's really important to have a therapist who's trained in these techniques apply them. It is it is a manualized approach, so many school counselors feel comfortable doing it, and it can be implemented at school. So it's good to be aware of this because it's widely accessible, evidence-based, and relatively cheap. So now I think we're going to take a break before we talk about psychopharm. We'll take a few questions and then a 10-minute break.
I didn't hear you talk about family treatment. So I often run into mothers whose anxiety exhibited before they had children, but it carries on and it sort of perpetuates, and I'm not really sure what you recommend for that.
I have no idea what you're talking about now. Yes, we see that all the time. I'm glad that you brought that up. So I think that's very common for a variety of reasons. I think that anxiety can be genetic, and then also it is true that I think the caregiver accidentally or inadvertently may increase anxiety by their actions. You're like, oh no, don't go there, stop. So family therapy is of the utmost importance. Sometimes, you might be so bold if the caregiver isn't aware that they have it or has never received treatment to consider that they get their own evaluation and individual treatment. But whenever you're working with children, it's so important to have a family approach so that everyone is working together and can implement those strategies.
I said mother, but it could be father.
Yeah, it's okay.
I was wondering, we have quite a few developmental optometrists in our area that are recommending vision therapy for ADHD and learning disabilities. I wondered if you wanted to weigh in on that.
I mean, I'll just say that it's not evidence-based. It's not evidence-based, and parents swear by it. The vision therapy, they say it really changed my child. So it's very costly, takes a long time. And I mean, if a parent wants to do it, that's really their choice. But there's no evidence to support its effectiveness.
American Academy of Pediatrics does not recommend
Does not. Mm-mm.
due to the lack of evidence.
And they actually have a statement out about that.
And insurance doesn't cover it.
Yeah.
That's out of market.
Some of them are starting to cover it.
Really?
Which is making it even harder to convince people to go away from that.
That is, so she said that in her area, some of the insurance is covering it.
Well, the placebo effect is real, so if they strongly believe that it's working, it may be helping them. But again, maybe they could get some evidence-based treatment.
Other questions?
Okay, so if you can come back at 3:15, that would be great. Thank you.